you mind if I just ask you a few general questions about the CLL, SLL thing to start with?
Yeah, of course.
I think the drugs are very, very interesting and everybody wants to know, but some people are newly diagnosed.
Yes.
And even the basic things. And we've had a question in from a lady newly diagnosed. I'm also sorry, I'm sucking on a cough sweet. I'm sorry, I'm having a mad cough moment. She's recently diagnosed and she's absolutely, her glands are really, really swollen. They haven't told her she's got SLL. So she doesn't really know, I think, what she's been diagnosed with at the moment. But presumably, if you've got SLL, it is normal to have these very big glands.
Yeah, so there's often a lot of confusion around the kind of nomenclature around CLL and SLL, and it's not always brilliantly explained. They're the same disease, effectively, and I think that's the first and most important thing to say to anybody who kind of maybe has been told, oh, I've got SLL and now I've got CLL or whatever. If you look at the definitions of both, basically, if you've got a circulating raised white blood cell level, so a raised lymphocyte count over 5, in the peripheral blood that you can measure in a full blood count, then you've got CLL, sort of regardless. If you've got a normal lymphocyte count and you've got enlarged lymph glands and you biopsy a lymph gland, then you've got SLL. So if you've got a normal peripheral blood white cell count, you've got, you've got SLL. But if you have an SLL patient and a CLL patient and you blindfolded them both and biopsy the lymph nodes of both, it's the same disease. Just one has a predilection. It's just a technical phraseology. It's just technical phraseology where one has got a predilection for, particularly for the lymph nodes and the spleen, whereas you sometimes see the condition where people just have normal lymph nodes or tiny lymph nodes and a really high white count and blood and bone marrow involvement.
For the lady who's written in, we should maybe suggest she goes and sees her consultant. Hers are very painful, she says. So yeah, if someone's got painful glands, they should go to a consultant.
So what I would say is, so anybody who has CLL, SLL, and has enlarged lymph glands, if you pick up a viral infection or you pick up some other reason why, or you have a recent vaccine or something, and you will still sort of develop kind of so-called reactive lymphadenopathy. So your lymph nodes will get bigger before they sort of get to your baseline. Right. It's quite unusual. In fact, it's rarely the case for CLL, SLL lymph glands to be painful without some other reason. And the most common reason is you're reacting to some sort of recent infection of some sort. Yeah, I think if a lymph gland sort of remained tender and extremely large and was continuing to get worse, then yes, absolutely, I would see somebody because I think that's it's just important somebody would look at it. But as a general rule, CLL tends to not cause painful lymph nodes.
Thank you. You right at the beginning of your talk, you talked about people being diagnosed, initial diagnosis. And do you think with COVID that initial diagnosis has changed for some people because they're just phoned up potentially and just you've got CLL, whereas you were talking to them about vaccines, different things. But COVID has made people not be able to go and see people face to face. It's stopped that happening. And therefore, the initial diagnosis for some people may be more scarier, frankly, because they're not.
Yeah, no, absolutely. I mean, I think it's a very variable. I think people have very variable experiences around the UK. I think it'd be fair to say around that initial time period. One of the difficulties certainly that we face as clinicians is that a lot of people are sort of diagnosed with a slightly, very borderline raised lymphocyte count, which sort of we know is highly unlikely to cause them kind of problems for a long time. But for that individual, of course, that's a very big deal to them. And they have all of these kind of understandably, 1,001 questions and want to know what's going on, etc. And so there's a slight tension that exists just in terms of sort of service delivery and the speed at which we can see people, and also the sort of patient's expectations. Now, in some places in the UK, and I'm kind of careful with how I kind of phrase this, but there were some places in the UK that are sort of quite light touch, perhaps, in terms of how patients are given information and how quickly they're seen from initial diagnosis, and other places try and maybe see people a lot quicker. And there is quite a bit of variation. And, it's kind of difficult to really sort of go too much beyond that. We have a system in the UK where we try and see everybody at least once face to face initially, because I think that's important. Now, when Delta and the initial kind of, the initial phases of COVID were kind of raging, that was quite a difficult thing to do. And actually, we did speak to people over the phone, etc., with the initial diagnosis, and tried to do that anyway, because I think as much to reassure people that, you've got a disease, explain what it is, but actually you may not need treatment for a long time, and at least to kind of allay some of the fears and try and give people some information. But now, and certainly over the last year or so, we've been seeing everybody face to face as quickly as we reasonably can do from diagnosis. And then in Oxford, we have a kind of nurse-led telephone follow-up service for the Oxfordshire patients, where if you've got very low risk CLL and you're highly unlikely to need treatment, and we've seen them once or twice or something in clinic, then people are quite quickly then moved across to a kind of much more light touch service, but primarily because they've just got very low risk disease, but they still have a port of kind of contact for any questions and stuff they have about
people should expect to people newly diagnosed. I know you can't say for the rest of the country, but people should expect potentially, or hope rather than expect, to see somebody now when they're diagnosed.
Yeah, I would like to say that's the case. I'm not certain it is everywhere. I think there are some places around the UK that will send a letter to the GP and say, this person's been diagnosed with CLL. These are the things to look out for. Please refer them back, etc., if these things change. As I said, I think there's a bit of variation, but I think a lot of places will see people at least once, which I think is right. But it's actually hard for me to really speak exactly what happens everywhere. But I think it is a little bit variable still. But it's certainly my belief that people should be seen at least once by a specialist, because CLL is not just simply, you've got a lymphocyte count of 10, you're going to be fine, off you go. It's much more than that in terms of, obviously, all the supportive care aspects to it as well.
But is that the case with people who've had treatment and are back on watch and wait? Because, for example, I know a lot of people who finished their treatment, say 4 years ago, and they're now just having telephone conversations with their consultant. They haven't seen a consultant for 3 years or something, or 2.5 years.
Yeah, I mean, I suppose that the kind of sort of the skill in managing a service, if you don't mind me putting it this way, is actually obviously managing the broad patient workload. And actually it can be really appropriate for people who are in a good remission, off treatment, who are well, to be in telephone follow-up at an appropriately sort of infrequent frequency, if you see what I mean. So yeah, I mean, if you had FCR, say 5 years ago, and your blood counts are normal and you're not getting infective problems, and you're well, and have no concerns, then I'd very quickly offer people to have 6 monthly blood counts, maybe once a year, phone call, something like that, because
that's reassuring for people, because some people particularly are phoning the helpline and saying they're anxious that they're not seeing it, but you're reassuring them that actually that's fine.
It's sort of the whole point of having something like, FCR, if you did really well from it, and the kind of the way I would view it is, the aim should be that you're having infrequent blood tests and you're fine, and you're having follow-up that's kind of appropriate, but isn't. I mean, you've always got to manage the tension between ensuring people's needs are met in terms of ensuring their blood counts are monitored frequently enough that reassures them, but actually not doing so in a kind of sort of overly burdensome and unnecessary way. But yeah, I mean, absolutely, we've got quite a few people who just have a once a year visit, actually, who are kind of following, say, FCR or something like that, who are doing fine. Yeah, I mean, you have to follow up people appropriately according to how they are clinically and their clinical context, basically.
And we've had some questions in about fatigue. Fatigue is something that affects a lot of CLL people, and a lot of them are told by their consultants it's not CLL related. And, I mean, I'm not the doctor, I don't know, but a lot of people, the question is, what do I do about this fatigue? I just, it's ruining my life. And another, if you can maybe in the same question, is quite a few people have written in about having achy joints with potentially a calibrutinib or ibrutinib, and what they should be doing. I mean, is it just something they've got to put up with, or what should they be doing?
Yeah, I mean, I have to say, I find fatigue one of the hard. I mean, this might not be a wholly reassuring answer, but I'll tell you what. I'll tell you the truth, and then at least you know. So, fatigue is one of the most difficult symptoms that I sort of face in clinic, primarily because it's often very multifactorial. You know, you think about things that make people fatigued in their life, and often it's very rarely one thing that you can pinpoint. I'm fatigued today in clinic, and I had an extra coffee because my 2-year-old woke up at 5 a.m. You know, lots of people will have a kind of multitude of reasons why they're fatigued potentially. I'm sure CLL does contribute. One of the difficulties is if you've got somebody who you wouldn't otherwise treat for CLL. So let's say you've got a normal hemoglobin, normal platelet count, you've got a raised lymphocyte count of say 20 or 30, and you know, a scan that shows very little, normal spleen, so the burden of disease is relatively low level. If someone is complaining of really profound fatigue, then I think it can be really difficult, because we know that all of the drugs that we kind of can offer people, be it chemotherapy, be it some of these newer drugs, which are great, but they have their own problems, as we'll come on to in a minute. Yeah. Like, you don't actually necessarily improve all of everybody's problems if you give them treatment. And I think that's where the kind of communication comes in, and being judicious about what you do is important, because a lot of the drugs will contribute to fatigue and not necessarily make it better, particularly if the driving force behind it is not the CLL.
Yeah.
But also, I would say that I have intervened a little bit earlier perhaps than I would have done if I was fairly convinced that the fatigue was being primarily driven by CLL.
And that's a judgment call you'd make.
It's a judgment call, I suppose, you make with a patient, and it requires some fairly careful communication. Yeah. It also requires people checking, for example, iron levels, thyroid function, check for diabetes, check for all other reasons of fatigue.
People should be doing that then.
Because I think you need to make sure you exclude all other medical reasons for fatigue if you're not convinced that the CLL is driving it. But of course, if you have somebody present with a hemoglobin of 80 and they're fatigued related to CLL, then it's straightforward. But the difficulty is when you have disease that you wouldn't otherwise treat and you have profound fatigue.
Yeah,
that's difficult.
Okay. Well, thank you. This is a good answer. We've got a load of COVID questions, which Nora Grant is a fellow trustee, and she's here with me, and I'm just going to read them out. So we're talking about, so somebody with CLL has COVID, gets COVID, and they get given the antivirals.
Just before we go into this, sorry, I didn't answer the question about our
joints.
Muscle. So they're both quite common. Sorry, very briefly, they're both quite common side effects of BTK inhibitors. So BTK inhibitors, if you look into the kind of medical information and so forth, you'll find that both that class of drugs, so acalabrutinib, ibrutinib, they both cause muscle and joint aches. Now, of course, they will be of variable severity. People will tolerate them in variable ways. In terms of how you manage it medically, basic analgesia is certainly one measure, but avoiding non-steroidal anti-inflammatories ideally, because they have an antiplatelet effect, and both acalabrutinib and ibrutinib affect your platelets and can make, your people will know that it can cause kind of generally minor bruising, but you don't want to kind of make that worse by using things like ibuprofen or diclofenac and so forth. Occasionally giving people brief breaks off treatment and then reinstituting at a lower dose is kind of the way you kind of tend to manage it if it's really quite bad. And it is a reason why occasionally people have to stop the drug, but as a general rule, most of the time it's manageable, but sometimes you need to dose reduce. And I guess it depends on the context and what an individual wants to do and so forth. But it is a known side effect of these drugs, and particularly with ibrutinib can be troublesome occasionally and can be a reason to actually ultimately stop it. I think if it's problematic on ibrutinib, it will. There is acalabrutinib available for anybody make sure I get the phrasing right here, for anybody who's been on Ibrutinib and is not tolerating it well, actually for whatever side effect. So the NICE approval for acalabrutinib is simply that you've had to have at least one line of prior therapy, and that can actually be Ibrutinib. So transitioning across those BTK inhibitors is a very reasonable thing to do. So yeah, if anybody's in that kind of situation, do talk to your consultant about it.
That's it really, isn't it? To go and talk to your consultant. Don't suffer at home alone, but just go and talk and see what you can get.
I think so. I think in the knowledge that acalabrutinib is now available in people who are struggling on Ibrutinib, it's just something to be aware of and talk to your consultant about.
So thank you very much for that. It's very helpful. So we've got a couple of COVID. I think we've only got 2 COVID questions to start with. Really, it's if you've got CLL and you get COVID and you get the antivirals, but then say you are very unlucky and got COVID again, can you have the antivirals again? Do you know that? Maybe you don't know the answer to that one.
Afraid I don't know the answer to that, actually. Fortunately, that hasn't happened very much. I don't see why not, particularly, but I'm sorry, I'm not certain of that.
So anybody who's got that question, I think the thing to do would be to talk to the COVID people. If you get COVID again, I mean, for us, when I haven't got COVID, the NHS jumped straight in. So
I think exactly. I think one of the challenges that we kind of face here is that whilst obviously a lot of the kind of concerns are related to COVID, we actually as hematologists don't actually treat COVID, and often find out about things almost at the same time as our patients do, because the government's kind of communication around COVID has been hasn't necessarily been to kind of like healthcare professionals first. It's sort of, there've been kind of public announcements, and people will come into clinic and kind of sort of tell me what I need to know almost on the day it's been announced, which is, just the way it's been.
I understand that. So people are asking about, do you recommend certain jabs, Moderna over Pfizer? But again, presumably that's out of your...
The problem is you've got to remember that the CLL patient populations that have been kind of sort of studied with vaccinations are the kind of the minority of people. And so the CLL cohorts that have been studied are much smaller than the larger clinical trials. So being certain about one vaccine over another, I don't think there have been particular kind of studies that have really demonstrated in CLL patients that one's more beneficial than another, particularly, as far as I know.
Thank you. Before we move on to another subject, do you have someone's written in about Evershell? Do you have an opinion on that, the ProVent trial? Do you have any thoughts?
As in the antibody, the kind of prophylaxis. I guess it kind of it potentially looks pretty effective. Long-acting antibodies are, theoretically what kind of people with no antibody responses need. I suppose we'll wait to see what kind of formally happens with funding in the UK. But yeah, I mean, you could certainly envisage a future where, you identify people who sort of by definition have low antibody responses and target them. I absolutely could see that happening. Again, these things relate to kind of sort of funding and approval as much as anything else. But,
absolutely. A question that's come in is about skin cancer, which I understand that people with CLL are much more likely to get skin cancer than the non-CLL people. And the question is why? Yeah,
it's a very good question. People don't particularly know why. I suppose some of the kind of genetic makeup of the CLL probably predisposes people a little bit. Probably the alteration in people's immunity may have a contribution. It's not fully known particularly why. They tend to be, just kind of as a word of sort of reassurance, they tend to be low risk skin cancers on the whole. So mostly tend to be basal cell carcinomas and squamous cell carcinomas. They're fairly easy to manage. But yeah, in terms of sort of why they're particularly prevalent in CLL, I can't give you a kind of very kind of definitive and clean kind of genetic answer, because I don't think that's known, actually.
Do you recommend to your patients that they have mole checks once a year or anything like that?
So we absolutely recommend kind of skincare and making sure you don't get burnt. Absolutely. I mean, I think if anybody, I think we generally just recommend have a low threshold for getting something checked out rather than necessarily, I don't know, paying a private dermatologist to look at their skin once a year. You can do, don't you know? It's up to you, but
you're not going to get that on the NHS, are you?
I don't think secondary care dermatologists would be particularly kind of enamored with seeing lots and lots of normal skin with CLL patients. So what we tend to do is obviously tell people to, not, do their best to not get burnt, use sunscreen, hats, etc. outside, and have a low threshold for any skin lesion to see their GP and make sure their GP knows that they're slightly more predisposed. We particularly see skin issues in men over 70 who've spent a lot of their younger years in the sun and perhaps have worked outside, etc. They're the group that really get a lot of kind of localized sort of skin cancers around the ear, the nose, and the forehead. That's where it's particularly common. But I think actually sort of younger generations who perhaps have been known, maybe people have known a bit more about skincare over recent years, it tends to be, I think, a little bit less of an issue, but it's still part of the kind of routine advice you give people.
Thank you for that. So now we're going to move on, if that's okay, to the drugs you were talking about, and that was a fascinating part of your talk. Are you still aiming for MRD negative? I mean, if you say you're not doing FCR, one of the things for people I know that did FCR was that they got to MRD negative, they were thrilled, and then they hopefully had a long remission. Indeed, 2 of our trustees, I think, have had 10-year remissions with FCR, which is fantastic. But my understanding is ibrutinib and calibrutinib, you don't necessarily get to MRD negative. So have you stopped using it as a
Yeah, I mean, so as a kind of routine marker in routine clinical practice outside of clinical trials, I do MRD testing in very, very, very few patients. Partly because the drugs, the classes of 2 kind of paradigms, the classes of drugs that I mentioned here, absolutely, BTK inhibitors given by themselves almost never cause or drive MRD negativity. They just work in a different way. They lead to a lymphocytosis that can be present for a long time. You don't tend to clear the peripheral blood and bone marrow with the same speed, but they control the disease, from what we know across kind of comparative, not, sort of looking across trials fairly equivalently. Venetoclax and obinutuzumab are very, very good at clearing the peripheral blood and bone marrow compartments, and so lead to MRD negativity. And that all that does is that all that does, but one of the key things that does is enables you to stop treatment. And it just, that's obviously a theoretical advantage. Certainly something that AbbVie will tell you is a major advantage, but there we Absolutely. Go. It's part of the kind of marketing strategy around the usage of that drug. But I mean, it's particularly valuable for, say, people who are, young people who still may be working, who, who have a kind of a high priority to want to stop tablet treatment or stop infusions or whatever. That it's like comparing apples and oranges, comparing the 2 classes of drugs and how they work, really.
So we just have quite an interesting question in now. Nora's just holding it up for me, but have we lost it or?
I've lost.
I think I can remember it. It was for, if you're saying that you're very unlikely to give FCR now, even with people with really favourable markers, I'm going to guess. Does that? I think the question was about removing the option. The people sometimes might feel, say they've got great markers. Do you never recommend it? You wouldn't say somebody who was 40. I mean, Nora runs the under 60s WhatsApp group. There's people on there mid-30s, I mean, they could do the venetoclax, obinutuzumab, but they, it's
because then the question is, what do you do next?
What do you do next?
The venetoclax,
so Nora is to my side. So
obinutuzumab.
Yeah, that's a good question. So I think it's a great question. The data that we have from the CLL13 study to date suggests that if you've got immunoglobulin gene mutated CLL, which is the group that you kind of over recent years, we still might have considered FCR in, those patients have a kind of 4-5 year progression-free survival of about 80+%, which actually is obviously relatively short follow-up compared to the FCR data that we have, which suggests that in that group, maybe about 50% of people are still in remission at like 10 years, but it compares fairly favorably. One of the issues with FCR, well, I guess there's a number actually. Well, one, it's obviously leads to quite profound fatigue, which sometimes doesn't improve. Two, it can often lead to kind of hypogammaglobulinemia, so low proteins, and secondary problems with infections, bronchiectasis, etc. Three, fludarabine will lead to prolonged T-cell suppression, which can affect people's response to vaccination and obviously theoretically increase people's risk in terms of kind of COVID. And then four, and probably the most important, although all of those other factors are important, is there is a secondary myelodysplastic syndrome risk with FCR, which is probably
a small risk, or is that quite a high?
It's probably of the order of about 2 to 3%. So it's not high. The problem is when myelodysplasia kind of occurs in that situation, it's genetically very difficult to treat, and can be really quite problematic. Whereas we know there's, from the data that we know so far, we haven't seen really a picture of increased secondary kind of blood disorders or secondary problems with the newer targeted agents. So I suppose for those reasons, FCR has become less popular. I would say that I haven't had anybody sort of bounce into my clinic and say, "Oh, I've read about FCR. I'd really like FCR now." It just doesn't happen.
No,
so even if I were a kind of FCR evangelist, which I'm not particularly, I wouldn't I wouldn't say there's been sort of great enthusiasm from patients either. I think particularly COVID's obviously played a major role there.
To answer this person's question, what I think you're saying as well is there's enough options. You didn't need that option. There's a load more other options. I think if you were kind of 40, let's say, and you needed treatment for CLL, then sure, of course, you've got to think long term and actually how are you going to manage these classes of drugs. I would say across the course of a treatment pathway, if you're dealing with like a 30-40 year time span, BTK inhibitors, BCL2 inhibitors as fixed duration, given potentially on a number of occasions, in theory you could have 3 bites at the cherry with venetoclax based therapy, according to NICE approval at the moment. The other thing is the non-covalent BTK inhibitors are coming. They will almost certainly be licensed. So Ibrutinib will, I'm sure, at some point become available. It's highly effective. And so to my eyes, you're looking at three classes of drug, which are all kind of distinct from each other to a degree and all work very well. And so you're looking at kind of potentially long periods of time without even needing to touch chemotherapy. So we've had a question in which I think it's quite a detailed question, so the difference between mutated and unmutated, but I think also from my knowledge with the new drugs it's not as important anyway. Am I right? I'm not as I think
that's true, absolutely. So just to kind of give people a kind of so historically, I don't think many people in the UK have tested somebody's so-called immunoglobulin gene mutation status. And there were kind of two groups, immunoglobulin gene mutated and unmutated. Patients with mutated disease as a general rule, but not, of course, necessarily just for individuals, but as a general rule, have a better overall kind of prognosis. They just tend to have disease which is easier to treat, etc. If you look at, say, how people do with BTK inhibitors, whether they're mutated or not, they do equivalently. So BTK inhibitors that absolutely overlie each other in terms of the clinical trials. That's not quite the case with venetoclax-based therapy. There is a small difference, the unmutated patients doing slightly worse than the mutated patients. Whether that information really influences whether you go for one above the other, I think is one of these things that kind of people at medical conferences like to kind of debate, but I wouldn't say is entirely clear-cut at the moment. And certainly it's not known whether giving one before the other in unmutated patients is better, really.
Okay, that's interesting.
That answers your question.
Yes, it did, absolutely. In terms of then choosing which treatment to have, maybe it's a first line or a second line treatment, because obviously a lot of people will have done FCR when it was the gold standard, and they'll be coming up to their second line treatment. So people are very interested in what to do second line.
Yeah, so second line, I think I didn't really talk much about second line, but second line acalabrutinib, based actually on a slightly different study, which I didn't show you, but acalabrutinib is licensed and approved, so that is given as continuous therapy. The other option is venetoclax, but in the second line treatment setting or beyond is actually in combination with rituximab, not obinutuzumab, and it's given for 2 years. That's based on, again, a different clinical trial. But the principles remain the same in that if you've had FCR, you basically still have both classes of drugs kind of available.
And you've still got the difficult choice as to which way to go.
You still have a choice. Yes, absolutely. What I would say, easy for me to say perhaps, but I think if there's no clear reason for using one over the other, and occasionally there are medical reasons why you might avoid one and the other, then I think both are really good options, and you will still have the option of the other one kind of following it. So we don't know whether venetoclax rituximab followed by acalabrutinib is better than acalabrutinib followed by venetoclax rituximab. They're almost certainly no better than each other.
You'd factor in lifestyle things at that point as well.
I would factor in absolutely individual people's preference. I'd factor in sort of whether people wanted to stop therapy or didn't mind carrying it on for a number of years. I'd factor in whether there are any particular medical problems somebody had that might sway you one way or another. More often than not, though, people sit somewhere in the middle and they haven't got an obvious and clear reason to go one way or the other. And then you kind of talk to them about sort of the pros and cons and give them a bit of time to make that decision, really. But to be honest, yeah, it's not that common that people are on, I don't know, warfarin for a metal heart valve or something, which might veer you away from acalabrutinib. But I would say that you should always use your kind of best one first, if you see what I mean. So partly because sometimes the drugs can work so well for so long that actually
don't need in the other one.
They're just never, the other one's just never needed because people actually die of other things. I mean, that happens.
Sorry.
So you should always use kind of your first one, your best one first, or the one that's best suited first.
And we've had one question about ibrutinib in, and I'm not quite sure why she's asked what the thing she was asking about stopping. I don't know whether she just wants to stop because she's feeling good, or does she say why she wants to stop now?
Well, no, just a question of can you stop your ibrutinib perhaps after you've been in a bit of a remission? You know, if you get to that remission point. Will there be a time when we stop the BTK inhibitors? Yeah,
that's a good question. So one of the issues about BTK inhibitors by themselves is you can stop them, but the remissions last. It depends. It depends how long you've been on them. It depends how deep your remission is, etc. Depends on some of the biology of your disease. But on average, if you've been on, say, frontline ibrutinib for 5 years, or say 6 years in the FLAIR study, because people stop at 6 years. The remission tends to last about kind of up to about 2 years, 18 months to 2 years. So it lasts a while, but it doesn't last for like 5, 6, 7 years. Whereas
some people in the FLAIR trial are having to stop, and they don't necessarily want to stop. The static isn't available yet. The static trial's not up and running. Is that right? And they're having to stop. So there's obviously concerns there maybe for them.
That is true. What I would say is that if those people progressed, they'd be able to go onto acalabrutinib, which is licensed and approved and is a cleaner BTK inhibitor. And if they stop and they then progress, it doesn't mean they won't be responsive to that drug. So I know what you mean, in that, you know, when people sort of signed up to the FLAIR trial sort of in the knowledge that they'd be, or it was kind of initially sold as continuous BTK therapy, wasn't it? But I think in the advent of acalabrutinib being available, actually sort of testing the theory of not taking continuous treatment is not necessarily, or not taking it like forever and ever. It's not necessarily a kind of conceptually bad thing, particularly as acalabrutinib is available. So yeah, I mean, we've got some people in that kind of situation, and you know, they have a they have this kind of sort of same class of drug available. What is more difficult is I think there's some snag in the NHS kind of funding, where if you stop Ibrutinib for more than 8 weeks, you can't then, I think this is right, you can't then reuse it within the same kind of line of treatment. Now, that was an issue before acalabrutinib came along, but if you had a toxicity, a problematic toxicity like, I don't know, pneumonitis or some kind of nasty rash or something from Ibrutinib, then people can just switch across to acala. That's not an issue, and the broad approval of acala is actually really helpful in that regard.
Thank you. I'm aware of time, and I know you've got a clinic to go to. My last question, maybe Laura's got some more questions, but you talked a lot about the trials, and they were fascinating. And I'm a great believer in trials. But how do people access them? Because it seems to me that there's an enormous amount of trials out there. Do they go to their consultant? Do they look them up online themselves? How do they find all these trials?
Yeah. So, I mean, historically, the CLL Forum has advertised clinical trials on their website. I can't really speak as to how kind of up to date they're all kept, because this kind of, the situation is always kind of in flux with trials opening and closing. I mean, obviously, there are some centres around the UK that will do more clinical trials than others, and there are so-called late phase and early phase clinical trials. The early phase clinical trials are done in kind of just mostly the major specialist centres. But I would say that all the CLL treating physicians at those major centres are always very amenable to discuss people who would be sort of in theory appropriate for clinical trials. And so
people refer themselves, or do they have to go to their own consultants and be referred, or do they go to their GPs? How does somebody get on your trial? Your trial sounds like a dream. How do people get on
it? Most of those patients got on the Loxo trial based on them reaching the end of standard therapies, and the physicians that sent those patients to me, well, they knew that, well, they either asked me for advice, or they knew that I had a trial open. And I get quite a lot of people asking sort of general advice from around the UK, just anyway. And so I suppose you kind of pick up people for clinical studies based on that a little bit. Each of the, what I would say is that the most centres around the UK should be part of an established regional sort of network with a major treating centre. And even if, say, for example, you were looked after by a district general haematologist, you didn't necessarily know what trials are open, they will still have a kind of regional contact who would mostly be dealing with CLL, who, even if they didn't know whether a trial was open, you know, they may well know that, I don't know, Dr. So-and-so has studies running. I could ask them. And actually, you know, that sort of from a medical point of view, the CLL was quite small. And we generally kind of sort of have a vague idea about what's going on in various places. And so if someone was, I don't know, in Nottingham and they didn't have a study open, then one of the consultants there could email me or whoever. And
you should talk to their consultants, really. Be
Absolutely.
aware that trials exist. Even if you don't know what the trials are, be aware that there are lots of trials.
Yeah, and I would say don't be, I mean, obviously I'm kind of very pro clinical trials, but they can be, you know, burdensome sometimes in terms of visits to hospital, but they do often enable access to newer drugs, and you know, that they're always asking kind of relevant clinical questions, and they're never going to sort of take a backward step in terms of kind of development. So yeah, do always think about that.
Always got to think a couple, but we know you've got to get off. We just got a very so this is quite a specific question. When is the trial on bispecific antibody CD3 likely to start? Do you know the answer to that one?
Soon.
Good. So the person who's been
one of the slight problems with these things is they're actually often, one of the things is the patients will ask their doctor when the studies are opening, and actually the doctors aren't actually quite in as much control as they'd like to be as to when these things are open. It's to do with contracting and pharmacy and all kinds of things I don't want to bore you with, but there are reasons why I can't be precise about sometimes these things, which is a frustration for me. It's soon. So I don't know who that's asking that question, but if
maybe we could, I don't even know how we keep in touch with that person, but we might try and
keep asking
keep asking your hematologist. Hopefully, I think that's the answer.
I think if yeah, well, I mean, I think if anybody wants to find out sort of more, then going via their hematologist and asking them to contact me is fine. I'm very happy with that. As I say, that happens a fair bit.
So we've run over and you've got a clinic, and thank you so much again. It's been fascinating to talk to you. Absolutely fascinating. Thank you as well for all the hard work you do for CLL community, because
no problem at all.
Trials are amazing, and I'm sure we haven't asked half the questions we should, but we're it's lovely to talk to you from all the CLL trustees. Thank you very much, and thank you everyone for listening. We haven't got another webinar booked in yet, but we'll let you know as soon as we have, when we've got one. Thanks very much, everybody. Goodbye.
Thank you. Bye for now.